Whenever something would happen, I would zoom out and say, ooh, that doesn't feel quite right. Often when we think about patients with fibromyalgia and all of the related conditions, all the judgment and shaming and grossness that goes on in the healthcare system. I remember as a medical student being like, no, this is terrible.
Yeah. With what exactly?
Like just seeing judgment, like shame and judgment from healthcare providers when you were in training.
I've been judged. But normal criticism going through practice. Part of that is why I'm still connected with the medical training and residency program. I'm switching to the residency connected health system. I'm in a smaller community and they asked me to leave. I think a huge part of it is because I work with the two most stigmatized problems, and you could probably put that under umbrella, are autism, or not autism, ADHD and fibromyalgia. And really, you start to see under that umbrella is I was interested in, really am interested also in the data that you have. It's one of these that you happen to walk in to this area and you start to see all of these interesting connections. There's a lot of ignorance in this whole area. I'm a pediatrician and an internist, lifestyle medicine doctor. I've always been interested in neurodivergent without even knowing it. I am editing the podcast for The Missing Neighbor. My mom, who's in heaven now, always had a big heart for people who struggled. My aunt, which was her sister-in-law, probably had the fibromyalgia, and she's passed now, but overlapping anxiety, depression. There'd be the lady who wouldn't come to the 4th of July get-togethers because she didn't like going out of the house. So my mom always had a big heart. My dad worked in a factory, but my dad had a big heart too. But just connecting and wondering, and always wanted to know there's another side of the story. And that's where I'm falling into this whole world of chronic pain and fibromyalgia and related issues. I'm interested to hear your story. The Missing Neighbor, if you're ever curious about connecting with him, he wrote the poems about his struggles with chronic fatigue syndrome, which I think is synonymous with fibromyalgia, and just all these synonyms for the same kind of problem. It's the missing neighbor. And even that person who doesn't connect, but I think there's a lot of overlap and interest, recognizing with a health system that's relatively small, probably typical of a decent-sized community system. They said, boy, you sure got called to a meeting without an agenda. And one of the things they said was, you diagnose a lot of people with fibromyalgia.
Turns out a lot of people are autistic.
You treat a lot of adults who have ADHD.
Yeah.
And you treat a lot of kids. And I end up as similar to you, but probably more from the fibromyalgia spectrum, but overlapping. I'm going to learn something from you today. I've listened to your videos and interview podcasts, and I'm sure a lot of people will be interested. And this is all coming together from my patient experience as a pediatrician and an internist. I get to walk both lines where things like autism are classically pediatric, but hey, gets into adulthood. What happens?
What happens to people when they turn 18?
And the same thing with ADHD and then overlapping fibromyalgia, classically that middle-aged woman thing. How are we reframing, understanding that I am an outlier because I've been taking care of adults and treating their ADHD for 18 years. I end up taking care of multi-generational family. Right. Once you connect, then they're like, and now I feel just like if I had a familial hypercholesterolemic patient, I'm like, you need to get your kid checked at age 2. Right. One of the parents has this. We are going to be more actively screening for. So I've been just how it's commonly accepted to screen for depression, and that's a quality measure. I have taken on to be screening for things like ADHD, at least in my mind. I have had a passion for helping people who are on the spectrum. I have a couple patients that are identical twins that now are into their 20s and both are differently affected. And I've gotten a chance to learn through them. I'm interested in, for the listeners, getting a chance to understand your story. And when you're trying to become a doctor and pick what kind of doctor you want to be, you're taking a waterfall of information and decisions and trying to filter out the relative importance of all of these. There's so much information that you have to learn and understanding. And I have so many questions for you. Like one, just off the top of my head, is certain people in the pediatric world can diagnose autism. Yet I've had patients where I'm like, they've been to the behavioral health. They said no, not to be judgmental, but I have a pretty good,
Just name the thing. Great.
I'm being perceptive, pretty good rapport, and I get a sense there may be something different. And the mom's, oh my gosh, I've been telling doctors this and nobody believes me. And I'm like, so I still take care of her. She's 19 coming in, intermittently taking her C meds. And now I take care of her mom. I take care of the siblings, step siblings. So that's where I have this multi-generational practice. I have 3 generations sometimes where we're taking care of these kinds of issues, which is how you end up growing a practice, just like you probably. I'm excited to get a chance to talk to you.
Me too. I would encourage you to look into whether the statement that you said about only certain people are allowed to diagnose autism is true where you live, where you practice. In Vermont, that is a commonly held belief amongst physicians. There are even psychiatrists who don't think they're allowed to diagnose autism. I got a lawyer. There's an educational law consult program here. So I got a disability-related educational law consult. I was like, can you help me understand this? Can we look at all the regulations, all the law, are there laws that govern who can diagnose autism? I can only speak to the state of Vermont. There are no laws that designate certain specialties allowed to diagnose autism. There may be regulations about who can access developmental services. And in the state of Vermont, having an autism diagnosis does not entitle you to developmental services anyway. You have to be autistic and have intellectual disability. So if we're not talking about co-occurring intellectual disability, we don't need to qualify for the check the box of developmental pediatrician, neurologist, psychiatrist, or PhD level psychologist. We don't need to check those boxes because we're not going to get developmental services anyway. If we are talking about a Medicaid guideline for certain types of treatments, namely the common treatment, I use that in quotes, of applied behavioral analysis. Vermont Medicaid only covers ABA if X, Y, and Z specialty made the diagnosis. That's the case how it is in Vermont. So I name those things transparently to patients and families, and I give them options, and then they have freedom and choice, and I respect their autonomy with whatever they choose. But I don't know if that's the case, if there really are state laws that prohibit you as the child's PCP from making that diagnosis, or the young adult's PCP from making a diagnosis, because it may be like folklore.
And thanks for challenging me, because I think this is implied, because I graduated med school in 96, residency in 2000, and all of these fibromyalgia and awareness of the autism spectrum have been in development, I think, during my medical school to present time, that are in evolution. And these were the people, metaphorically, using biblical language, like lepers, that were often outcasts when I talk and misunderstood. And we have 2 cardiothoracic surgeons that one runs with primary care and specialty. That's how they don't know anything about this stuff. And Kate said, you're getting evaluated by people who are surgeons. And I think that the people who may be in primary care above me don't even understand this. So you understand that these chronic issues are way underdiagnosed, I'm realizing, way under-recognized. And I started to connect the dots and start to see how these overlapping. Now, there's another layer that I'm really excited to learn more about from you, is that spectrum, and then that there's an overlapping component. I did a survey on one of the Facebook groups that I'm involved with in fibromyalgia, and I said, just a quick survey, I said, how many of you feel that you for sure strongly feel that you are neurodivergent? That was choice A. Choice B was, I'm not sure, I think I might be, and I'm pretty sure I'm not neurodivergent. And about a third said, I'm pretty sure I'm neurodivergent. A third said, I'm not sure, I might be. And a third said, and so I'm getting that conversation. And it's interesting if you don't ask the right questions. And that's where I've had patients say to me, Dr. Lenz, I've never had a doctor ask me questions that you are asking, because if you know what to look for, as you probably know, suddenly you see it. And I have
Yes.
a medical resident that works with me for 4 years doing med peds or continuity clinic. And he knew right away I was a weird doctor because of exceptional, different in that I would actually diagnose these that nobody else would diagnose. So if you've listened to some podcast episodes, I try to emphasize I take an evidence-based approach. All right, I'm excited to finally connect Dr. Mel Hauser. She is a family practice doctor, and she has some real lived experiences working with those who are in the neurodivergent community, both as patients and within her own family and within her own self. So welcome to the podcast.
Hi, it's great to be here.
So awesome. There's so much to talk about today. And what's interesting is that many people who have a neurodivergent type style nervous system and mind also have some coexisting chronic pain, fibromyalgia related issues. So that's one of the big connections that this podcast is about. But I think it's also just to grow and gain some greater insights. Before we dive into that, can you just tell us more about your background?
Absolutely. I'm a family doc caring for neurodivergent patients across the lifespan. 15 months ago, I founded a nonprofit organization called All Brains Belong, which is a community health organization in Vermont that provides neurodiversity over medical care, but also a wide range of community and education programs, all aimed at trying to make life better for neurodivergent people. Maybe what I also could say, just in case that term neurodivergent is new for folks, maybe I can just describe what I mean by that. So when I use that term, I'm referring to the 1 in 5 people whose brains work in ways that significantly depart from the ways that society has deemed typical. Since folks are listening, not watching, I'm using air quotes when I say typical because I don't think there is a typical brain, although society really does give people that message. So anyway, some neurodivergent people have specific diagnoses such as ADHD, autism, dyslexia, dyspraxia, etc., but most do not have specific diagnoses. Anyway, I probably for the past 6 years or so, working in the last chapter of traditional primary care, my practice has focused on supporting neurodivergent kids and adults, often multi-generational families. And what I saw is that those patients were not having their needs met, both in healthcare and outside of healthcare. Kids getting bullied in school, struggling to have their access needs met. Adults struggling to access employment, struggling with social isolation, and really people of all ages getting not their needs met by the healthcare system. And I think so much of this also relates to the defaults of society. To become a patient, you must fill out the 20-page packet. To make an appointment, you must pick up the phone. In school, you must sit in the chair with your hands folded. It's like all these defaults, but there's not a default brain. And so there's just a lot of barriers to access and a lot of othering. And then when I became the parent of a multiply neurodivergent child who's 6 now, the urgency really set in that I needed to do my part to really shift the broader community conversation on neurodiversity and inclusion. And to break free of the restrictions imposed by the traditional healthcare system. And the idea of zooming out, reimagining what health is. It's not just medical care in the office, like health is community. Health is making friends. Health is accessing your education. Health is accessing your employment. Health is showing up authentically as your true self. And for some people, feeling safe for the first time.
Great. That's a good introduction to that. And what about yourself in your own career? Finding out you had a neurodivergent brain, so to speak.
It's interesting, like before I gave birth to Luna, here I am, a family doctor, like taking care of babies, had expertise in child development. I thought knew what I was doing. I did not know what I was doing, turns out. And Luna made it really clear that I did not know what I was doing, and that my medical knowledge was really lacking. To my knowledge at that time, I was not aware that I had taken care of an autistic infant before. I, of course, have many times, but didn't know it. And I really learned about the practical day-to-day life that involve adapting the routines and environments for Luna to thrive. And that's really how I learned most of what I know about brains. And along the way, I learned that I have a lot in common with Luna, it turns out. But it was not until early in the pandemic, with the physical and mental exhaustion, taking care of patients in the hospital, just really being overtaxed by the strain of all that was happening. At that time, a job that was a poor fit for my needs and caused me a lot of sleep deprivation, caring for patients on call, et cetera, homeschooling a then 3-year-old, chaos, if you will. And that resulted in something called autistic burnout. And many late diagnosed or late identified autistic adults get their diagnosis in the context of autistic burnout, where that state of physical and mental exhaustion really coming from years of being severely overtaxed by strain. At age 37, I learned for the first time that I was ADHD. I learned that 6 months before the burnout got worse, and then I got my autism diagnosis. The DSM criteria for autism are autistic stress behaviors. And the more disabled by the environment you are, the more stressed out you are, and the more likely you are to appear more stereotypical DSM criteria. So anyway, that's what happened to me, and that's how I got my diagnosis. And then that's later that year, I also learned that I'm dyslexic, dyspraxic, and dyscalculic. Like, yeah, that would have been really good information to have 37 years ago.
All right. So you must have just lied on your MCAT, your med school application, because smart people people who are struggling, they can't get through med school, right?
Myth. Myth. I mentor many neurodivergent medical students, and it's just the ways in which the medical education system drives masking behaviors. And by masking, I'm referring to involuntary covering up of your true self. There's this narrative of fake it till you make it. There's so much imposter syndrome, but it's really, this is so hard. And I look around and it looks like no one else. It turns out it's hard for a lot of people. It's hard in a lot of similar ways to other people, but no one talks about that.
Masking and the effort it takes to get through. And you had a lot of gifts and areas, obviously, to get through medical school, and had a lot of drive. And it's a blessing that you got through, because you are now helping people you didn't know that you were going to be helping people in this way when you started your med school. Interview question was, why do you want to be a doctor? Is I want to start a neurodivergent clinic in Vermont. If you would have seen the future,
Right.
you would have been like, what's neurodivergent? And
Exactly.
you're neurodivergent. Yeah,
I
I'm
wouldn't
fine.
have, I wouldn't have known that. And I think when we think about fibromyalgia and the overlapping medical conditions, a year ago, I would have been surprised by this, which is that 70% of my practice has a pattern of multi-organ system neuroimmune conditions related to connective tissue, mast cell activation, hypermobility spectrum, fibromyalgia. We refer to this around all the brains belong as all the things, because mostly all the people here have all the things. And amongst the neurodivergent adults, 95% have all the things. And when I knew that each of these conditions, including fibromyalgia, is more common in autistic people and ADHD people in general primary care, the people who come here are people whose needs were not met by the traditional healthcare system. So you have neurodivergent people whose needs were not met by the traditional healthcare system. That is going to be a self-selected group of people who are more likely to have all the things. And I think that what has also been really helpful about that is that we've gotten to learn a lot from elevating the expertise of those with lived experience. And so we've had a year ago, we formed a community task force of multidisciplinary clinicians and patients to really try to better understand not only what are best practices, but what are things that are harmful in the setting of all the things. Because, for example, when we have internal conflicting needs, for example, if I have POTS and I need compression for my POTS, but I also have extra stretchy blood vessels, now my feet are purple, thanks. So I have to figure out, or if I need stimulant for my ADHD, but I have hyperelastic stretchy blood vessels, and now I have more brain fog on this particular stimulant at this particular dose. Now because I'm vasoconstricting and I'm not getting blood flow to my brain in the way that I need it. I need the dopamine, but I also need blood flow. So it's this really interesting balance of internal conflicting access needs.
Very interesting, very intricate, very multi-directional, and a lot of back and forth feedback going through all of these different organ systems. What was a time frame when this started to click for you?
It was before I quit my job, actually. I started to see it toward the tail end of my time in traditional primary care. And how it all started for me, actually, I saw a lot. I saw it was summer 2021, and I had seen a lineup of ADHDers who had signs and symptoms of sleep apnea, which of course is known to be more common in ADHD and autistic people. I sent them off for sleep studies, and they all had sleep apnea. I thought I was just doing like my due diligence of being thorough. I didn't actually think they all had sleep apnea, but they all had sleep apnea. So then I made my doctor send me. I think I had just got my autism diagnosis, and I made my doctor send me. And at first they were like, "What are you talking about?" Anyway, like, I'm not the first person to spot this. I did not make it up. So anyway, so that was how it all started. I said, "Oh, okay, that's interesting." And then of course, as I said, there's literature on each piece of this. So migraine and autism, fibromyalgia and autism, dysautonomia and autism and ADHD. And I think about autism and ADHD as overlapping Venn diagram circles with a pretty large middle sphere. There's literature on each piece of all the things connected to autism and ADHD. And the zooming out came when I started this practice, and more neurodivergent adults whose needs were not met by the traditional healthcare system, they all had this much bigger picture. And in fact, my practice filled up 6 weeks in, so I had to hire a second medical provider. And I said, "I'm worried that I'm biased. I'm worried that I'm seeing things that are not there." And she said, "No, all the people have all the things. We screen all our new patients. A lot of people come here because they know they're neurodivergent and they're looking for neurodiversity affirming healthcare. But the people come because their physical health needs are not met by the traditional healthcare system. And amongst those people, they are far more likely to have all the things. And if you have all the things, you're far more likely to be neurodivergent." So it's like the pathways to adults discovering their true selves and how their brain works. I think that their autistic burnout, as I said, is a common pathway. The other thing in common with my journey, my child is found to be neurodivergent. So I learn about brains and I learn that I have a lot in common. And so I start wondering about my own brain. And then this third pathway of I have all things.
Great. So many important insights that 95% of your patients that you see who are diagnosed,
Patients who aren't known to be neurodivergent.
so adults who are neurodivergent have one of all of the things, which would be one of the overlapping pain syndromes of fibromyalgia, migraines, IBS, irritable bladder, irritable bowel, POTS. All of those are hugely overlapping Venn diagrams, and they're just like anything. When you learn, those are good for structure, and in med school you have certain criteria that works great in the medical model, and then it gets muddy. I had a interview for a podcast, and the woman who has fibromyalgia, she said, "Dr. Lenz, just talking to you, I think you like getting big yarns of tangled balls of yarn untangled." Bruce Campbell about narrative medicine and how it's so important to get a story and seeing how all of these are connecting. And I think that if you don't ask the right questions and you don't know this is a possibility, how many people are we missing? And that's a similar question I had. Why do I have these and other people don't? And part of it is, if you look for it, there's at least 2 doctors who do regular medicine who aren't subspecialty focused therapist who works just in the autistic spectrum or occupational therapy, but somebody who actually can also treat your diabetes and treat your migraine and treat your blood pressure and treat your high cholesterol, help you get through other struggles that often are comorbid, coexisting with the other things. That's a neat word. And at least being validated. I know a lot of people who have read my book, and you showed the book there, and who've said they'll cry after the first 4 chapters because there are some stories in there of a lot of people not getting their healthcare needs being met, and to right off the bat recognize somebody actually understands that my brain works different. I interviewed the author of Your Brain's Not Broken, talking about ADHD and all of these overlapping things. And it's that same recognition. Your brain's not broken, but it does have a different software operating system. And that's the common language that people in the area, and having to unfortunately use the word disorder, I'd probably call it a distress, is a name, that attention deficit hyperactivity distress. And there's a lot of this stress testing metaphorically in life that happens that suddenly unmasks somebody's genetic predisposition if they're not aligned in a perfect job with a perfect social situation after. And then life just happens. You could have a parent who gets diagnosed with dementia, has a stroke. You have extra demands. I had the whole podcast series in honor of Margaret Mitchell, who had a lot of gifts, but she talked about caregiver fatigue. Those are things that just happen and make it extra challenging. So I really appreciate talking to somebody else like yourself who works in the primary care world. Is that your observation too, that there is a big lag in understanding these connections within the primary care community?
I think that I have a lot of things to say about it. First off, I just want to clarify. It's not that 95% of the neurodivergent people have one of the buckets of all the things. They have cluster. They may not have all of the buckets, but they don't just have one. They have more than one because they're all related. The system interferes with the individuals being able to see the pattern. I think the system, especially in settings where there's the pressure to see 1 million patients, see people every 10 to 15 minutes, work in this terrible electronic medical record, which, by the way, is a neurodivergent person's nightmare a lot of the time. It's very hard to have the bandwidth and even the full access to your cortex in that setting. If you are just trying to survive and you're treading water at all times, you don't necessarily have access to the skills that you have, which is to pattern match. And so this is a pattern matching exercise. And I think one of the things that is challenging is that medical education is often based top down, right? So you have an autistic patient. These are the 40 co-occurring conditions that are commonly associated with autism. Okay, that's all well and good, but that's not how the patients come in. That's not how the patients come in bottom up. And so the task, you mentioned narrative medicine, I think the task is to provide a narrative for organizing this, because the patients need a narrative also. So I can't tell you how often it is that someone comes in with 40 diagnoses and they feel so broken because clearly I must be broken if there's 40 things wrong with me. And I say, oh no, you don't have 40 things wrong with you. You have one thing. It's called all the things. Oh, and by the way, let's talk about your brain. That's how those conversations tend to go here.
Great. And I just this afternoon, in between volleyball games, was editing the podcast script for talking about neurasthenia, which is a term in the 1800s that died out in the 1920s for the most part, that would have been a word for all the things. So I haven't finished the script for that podcast, but I'm calling it, to be exciting, a cold case closed, because they couldn't find anything organic wrong when they did, as you could imagine back then, trying to find the pathology of the cancer, the infection, to explain this. And it fell to the wayside because the medical model, which was doing great things as you get into the era of penicillin, this guy named Freud threw in a whole chunk of misunderstanding and led us down some pathways that didn't speed things along, and dismissed the people who were doing this neurasthenia work, which was really neurodivergent work, who had compassion. And they had this idea that there was this electrical charge in your body and you could only hold so much, and it could only have so much capacity, and you could be drained. And that sounds like what happens with people who have all the things, the fibromyalgia and related problems. That sounds, and if you can pause and understand, it's incredible, many decades of their life that they've lived before they finally get a diagnosis. And I often will say, it's going to be bittersweet. The sweet part is going to help you improve to whatever degree. And when it's fibromyalgia related issues, hopefully we can get you close to the distress level of somebody who's not affected. Sometimes we'll take you from extreme to moderate. But that's the sweet part. The bitter part is, I wish this wasn't diagnosed earlier. And I have many people who I think, and they tell me this, Doc, you saw me in one visit and you figured this out in one visit. I've been seeing doctors for years. And part of what inspired me to write the book, and now subsequently with the podcast, is not everybody quite believed me. And I didn't have a great resource to say, here's some evidence to support this understanding. I was seeing this with ADHD. And is it just me? And then you start seeing Dr. Joel Young, who wrote the foreword to my book. He's seen that and had case reports and then did studies about this. And oh, okay, so it's not just me, but I was treating people who had ADHD. And when their ADHD was treated, their fibromyalgia related symptoms improved. And part of seeing how they are all connected is that stepping out, that bigger picture. For anybody who wants to see you or me, I sure you would, and I would both appreciate if you can take time to write your story, often if it's going back to childhood, and sit down with your spouse and your parents. And I've had a patient recently who did, and they had a 3-page laid out story. And there was a lot of sad things that happened. And then there's also even reframing that there's such an inheritability of a lot of these things that sometimes they had really bad things to think about relatives in their lives. And then to pause and go, so maybe your dad, who you thought was terrible, had been compensating for their burnout with using alcohol, and that now you maybe understand them better. And it can be pretty wow. So what's your experience with the diagnosis for people who are naive to this all?
There are no words to describe what that's like, because I think for so many people, it shifts them. It's not instant, but it's the pivotal point to being on a journey of self-discovery and self-actualization, as opposed to being stuck in this deficit-based narrative that has been provided to them by the rest of the healthcare system. The other thing that's really also we find here, because we do a lot of group medical visits, that connecting with other people who are navigating similar healthcare challenges. So it's not in addition to peer support, we are also doing medical management. It's sometimes healthcare has this narrative like you're choosing between support groups and healthcare.
One thought that came to my mind earlier is you mentioned how the classic criteria for making the diagnosis of autism is when burnout has occurred and compensatory mechanisms are now failing. And I think that there is, for as many different people that you see, there are many different reactions. And I think for many people who may be, if you want to say, on the lower to moderate distress, which is I think a lot of people simmering that may not present into the high or extreme range is that they may be resistant to the diagnosis because they have worked so hard to overcome that by bringing this up may be interpreted as you're failing and you're a failure. Can you comment on that?
Yeah, I think that's really reflective of systemic ableism. It's not an individual's fault. It's society's. That narrative comes from society. It's the messages that we get from toddlerhood about that there's one right way to be a person, and you better present that way, and you better be able to show up in a way that is the correct way. And so when you are working so hard to do that, just there's a lot of internalized ableism. So ableism being the belief that it is superior to be able to do the thing. And like all of the many discriminatory isms in society, it's profoundly bad for health.
And obviously, there are just realities of life where people, you have to get a good grade on your organic chemistry, and you had to at least get some decent grade to get into med school. And we have these obvious things, whether it's in sports or a job you have to perform, otherwise you'll get fired. One of the things you mentioned on another interview, and I think you touched on a little bit here, is the impact of the autism spectrum on functioning in life. One of them, I think you mentioned the unemployment rate. Can you share some?
80% of autistic adults are unemployed, including those with college degrees. And this has to do with, I'm going to use the term access needs. And we all have access needs, whether you're neurodivergent or not. Access needs being anything that a person needs to fully and meaningfully participate. And in my practice, there are a lot of challenges around finding and maintaining inclusive employment related to people not having their access needs met, although they may not have that language or that framework, where there may be, for example, interpersonal conflict. There may be issues around executive functioning that is unsupported. There may be issues around motor planning and coordination related to technology or otherwise that's not supported. There's all these things where people don't have their needs met, but that's not the narrative. The narrative is you're fired or you're not a good fit here. That has an impact on health.
And if you have that happening over and over, then there's that underemployment or unemployment where people are giving up. So when you have, speaking on that employment, when somebody is getting support, starting with the diagnosis, awareness, what have you seen in your relatively short time dedicating your career to helping people in that struggle?
Makes all the difference in the world. I think so. Albrains Belong has a community advisory board. So there are people of the community we're serving that inform our priorities and programs. And one member of our community advisory board once said to me that for them, employment is so fundamentally part of health. It's so fundamentally a part of their identity. And to struggle so much in accessing employment, that narrative of I'm broken, I'm defective is just so difficult to cope with. And so we, from a fairly early stage in the organization, took on employment related support as like part of what we do. So we have our medical piece, we have our community education piece, we have our social connection, helping people make friends and social relationships, kids and adults, but employment support. So we have a couple of different employment support programs for our patients related to bridging gaps in access needs. But we also have part of that we have a cohort of people who we're supporting them in launching their own businesses, because autonomy is an access need for many people. And so that's what we're supporting. It's everything's a balance, right? So if I have an access need for autonomy, which by the way, I do, and I struggle with executive functioning, which by the way, I do. I have to belong to an interdependent team. I think independence is so overly glorified in this society. Autonomy is critical, but I think people use independence, doing the thing by yourself. They use that when they mean autonomy. You have control over self. I have self-determinism. Plus, I belong to a group of people that I am connected to and rely on. There's no shame in that.
So a lot of people listening, and I did an informal survey in one of the Facebook groups asking, this is for a fibromyalgia Facebook group, and I asked the question, how many of you are pretty sure you have a neurodivergent mind? Many people asked, what does that mean? Because I'm glad you defined that in the beginning. And there were choices. One was, yes, I'm strongly suspect that I have it, or I've been diagnosed with that. The second choice was, I think I might, I'm not sure. And the third was, I'm pretty sure I don't. And about a third of people said, I'm pretty sure I do. And a third said, I might, I'm not sure. And the other third said, I'm pretty sure I don't. So the question I have for myself, because as a pediatrician and as well as an internist, I have the blessing of having the longitudinal spectrum smashed together without delivering babies, which that would be the family practice training aspect, but I knew pretty well I wasn't going to do that. So I wanted to have the broad. So I have had the traditional understanding of the autism spectrum from a pediatric training. I would bet very few internists have any training more than just what they've seen in movies, Rain Man or something like that. And probably some have in family practice have some training. It probably really depends on just a makeup of some patients that they had in clinic or a provider in the area who has a special interest. So for those who are listening, which are mostly adults, but many people have children of their own as well, but applying that to adults, what two questions. The first one is a quick answer. Approximately what percent of adults who have autism spectrum have actually been diagnosed? And then the second part is, what are the signs, symptoms that you might have?
Yeah, answer that question in a couple of different ways. We don't necessarily have data to answer that question. What I would say is that what's described is like 2% of adults are autistic. That's obviously just wrong. There are studies of autistic adults, like diagnosed autistic adults, and assessing the prevalence that were diagnosed prior to age 18. I don't know the number. I'll look it up. I'll find the study. You can link it in the show notes if you want, if people are interested, but it's a very small number of people. So that's, I think, the real message. The stereotypical teaching is of one slice of the autistic population. And at least the way that I was trained, and many of my colleagues have been trained, the stereotype is that of the non-speaking 4-year-old cis male. And that's not most people. So anyway, I think that, and there is research, and there's a study from 2015, Zerbo et al. In primary care, comparing the actual number of autistic patients versus the perception of autistic patients. Huge disconnect. It's something like only maybe fifth. I think it's something, I might misquote this, so maybe edit this part out, but it's less than a quarter of the people were known by their primary care doctor. There are studies of autistic adults. Only a third of autistic adults even tell their PCP that they're autistic for fear of judgment.
It's only 2%.
We can't the unknown.
Sure.
So yeah.
So you said it's obvious. They say 2% of adults, and it's obviously that's wrong. What is the right answer then?
Yeah, I don't know that we know that. I don't know that we know that. What we do know is that there is increasing recognition that adults can be autistic. That is increasing, because like, how could that not be true? What happened? So why this is so important to me, and this is actually, I didn't tell you this when I was telling you the story of While Bravest Belong, but what gave me the sense of urgency is that shortly after I got my autism diagnosis, I learned a statistic that the average life expectancy for an autistic person is 36 to 54 years of age. I was 37, not dying from autism, dying from premature cardiovascular disease and suicide. To me, that's so messed up. That's so messed up that like the healthcare system doesn't even, I don't think people even know that. Even doctors who take care of autistic people don't know that. And I think the chronic toxic stress of living in a world that's not designed for you, that contributes. But I also think all the things contribute. So all of what we've just talked about, this neuroimmune response, is going to increase risk of cardiovascular disease.
And we know, at least I was aware of the data showing by Dr. Barkley that adults with untreated ADHD have a 13-year shorter lifespan. And if you're thinking if you make it to adulthood or even to elementary school, life expectancy is upper 70s to low 80s. And that, if you're saying rounding it to age 50, that's 30 plus year shorter lifespan. And so we do a lot of things in medicine, and we're going to get to the question we're maybe teasing here. If all the listeners are wondering, maybe I have it, or if they're listening, if they wonder if their spouse has it, or their sister, or their mom, or their child, if they have it. But we do a lot of screening in primary care. Newborns, we check for rare genetic disorders that could kill a baby if they're not picked up and cause or severe health issues, but they're very rare. We screen for cholesterol problems that are genetic, and I'm a clinical lipidologist, and of course, untreated familial hypercholesterolemia can lead to premature heart disease because of just the cholesterol with a neurotypical brain. But I've had the mindset that these are things, and when you start hearing the data, and when I heard the data about the 13-year shorter lifespan, that made me think this is important, and to not recognize this is doing everybody a disservice. And the data that you're sharing is so important, that this isn't, it's an optional diagnosis. It's optional whether you diagnose it. As Dr. Dobson shared on a podcast of a colleague that really irritated him because he said it was optional whether you diagnosed ADHD and it was optional whether you treated it. And those are people who unfortunately aren't seeing the data. But if you can share that article about the shorter lifespan, if you can email that to me, and I'll try to have a post because that is very impressive. So getting back to the teaser of how might you, if you're an adult, that you might, what are the signs, symptoms that you might be having and the criteria or making that formal diagnosis? And maybe you could, a case that you might have of somebody that is pretty common that you might see in your clinic, especially if they were undiagnosed, not coming in with already the diagnosis.
So the way they present is with all the things, first off. So I think take-home point, if there's a primary care doctor listening and their patient has all the things, I would wonder if they're autistic. That's, I think, an important take-home point. The second way I would answer the question, and I don't mean to be difficult. It's just that for me to rattle off the list off the DSM criteria, it's the same DSM criteria. It's really, we're in the wrong paradigm. When we talk about screening, the idea that you would screen for something that you would then want to do something about. And when I say do something about, like, support self-understanding and the adaptation of environments and routines to meet your access need. But that's not what most people mean when they say do something. So in healthcare, when we talk about screening for autism, we're talking about a very deficit-based paradigm where we are looking to fix, cure, prevent, treat the way that someone's brain is wired. So that's why I'm having this response to the question, because I think we have to first work on the healthcare system having a different way to be thinking about understanding, for example, monotropism. Monotropism refers to, this is like neuroscience understanding of ADHD and autism, that autistic and ADHD brains tend to fewer things captivate our interests and do so more intensely than other brains. Yes, I identify as a monotropic brain. So, for example, when I get a call from a parent yesterday, and they say, little Johnny is only talking about dragons at school, and we're trying to figure out how to get little Johnny to learn how to play with all the other kids and talk about all the things that the other kids talk about. It's like, little Johnny's monotropic. Little Johnny literally can't think and talk about anything else except for dragons. So the idea is not to get little Johnny to mask and hide their true selves and talk about the things that all the people want to talk about. It's that we find little Johnny a friend who loves dragons.
Yeah.
I have a monotropic focus on brains. It's pretty good that I have the kind of job where I can think and talk about brains all day. There were periods in my life where my monotropic foci were other things, and I had friends who cared about those things. And when someone has a monotropic focus in common with other people, they may not experience, quote, difficulty in making friends. So when you look at those DSM criteria, you're really looking for a mismatch between the way someone is and their environment. I do think that one of the things, there's an instrument that I find interesting and useful. It's called the CAT-Q, refers to camouflaging or involuntary masking of in adults, looking at to what extent your social behaviors are learned. And it asks about at different times in your life, things you did. That's an instrument I find actually useful information to get from my patients.
It's often in the beginning where I have a patient who has distress. It's trying to identify and share with them that you have a lot of distress. Admit it. But you also are not the way fixable, but we can help you manage your stress and get through distress and get through this better. Dr. Holloway, who's done a lot of work with ADHD, talks about strength-based approach, is recognizing that. And I think for so many people who are struggling, talking about unemployment, is I've always had that encouraging mindset when caring for people that, hey, I don't want to just be Tony Robbins, think positive thoughts, but hey, what about this? And I just posted on the Facebook page, Fibromyalgia, at the time of the recording, about who in here has an interest in art. And then people posted, one of the ways I get relief is painting or drawing or photography and finding that interest. So getting back to, talking about shifting the paradigm from a disorder, but there is real distress and we have to classify things, and that's just how medicine is, but also not taking away that there aren't strengths. But just because there's strength-based approach, it doesn't mean there isn't also distress. And the documentary I call The Disruptors, talking about ADHD, it does the yin and the yang, that balancing act. And Will.i.am, who is in the documentary, a very talented music artist, says some expletive to them. It's a superpower. And I think that's because so many times they've been told that you aren't good at something or you're struggling and they've overcome.
Let's talk about that, though. I think that when we talk about being neurodiversity affirming or that we're celebrating the strength of all brains, that's not to say that there are not impairments, that there are not things that are hard. There are some things that I really don't do well, and it really causes me a lot of trouble. And the idea is that I design a life that works for my brain. And I mentioned in the workplace, I have an interdependent team comprised of people whose strengths complement the things that are really hard for me. Or there are some things that when I think about something like 80% of autistic people have motor coordination or motor sequencing challenges. There are some things that I can do them. I just can't do anything else for the rest of the day. So I'm going to choose not to. So I think just like self-awareness is really important. But I think what a lot of adults who learn that they are neurodivergent for the first time in adulthood. And by the way, I think self-identification is totally valid. I have a formal medical diagnosis, but I in no way think that people need one, that's like blasphemy to the healthcare system, right? Unfortunately, there's this I'll send you, if you're interested, I'll send you a talk I gave last year on like how autism got into the DSM. It's a story I never knew, and a terrible story. It's a story of corruption. And I think there are many things things that have been taken out of the DSM that were never supposed to be in the DSM, but were. I think this will one day be one of those things.
One of the limits always, though, is paying for the rent, paying for the lights, paying for the salaries of yourself and the support staff. So having to have something the insurance company that you can have, and if you're doing research and trying to understand this, you have to use names, and as imperfect as they are. Talking with Dr. Bruce Campbell, we did the narrative medicine discussion, and he's an ENT doctor, which I said, that's really interesting. ENTs, I usually pretty much probably see you once in your lifetime, but there's some longitudinal care, and unfortunately, in regard to cancers. But he said people who go into primary care do better with ambiguity, and people who tend to go into specialties prefer less ambiguity. They like that straightforward. And I like the ambiguity in one sense and recognize it's there. And that's a hard part of recognizing, yes, we have a true medical model that does great things. There's things that are clear cut. You have a statin, lower that cholesterol level, relatively blood pressure med, insulin, antibiotics. Those are great, and those are gifts, and they happen to people of all types of brains, and they don't discriminate necessarily. But when you blending in that biopsychosocial spiritual concept, which is that whole person, that whole picture, and hopefully, as we talk about this podcast, this is meant for you if you're living with this. So that hopefully has given you some validation and understanding. One of my patients, 75-year-old patient of mine, said, who has family history and long history of a lot of distress, and she's made it to 75. But when she finally had her ADHD diagnosis, oh, that completely makes sense. I was at the 99th percentile academically, but I never performed. And the teachers always would say that. But that makes so much sense when I look back, and then you start looking at the family tree and understanding the generation equal and above you, and then the generations below you. And seeing how all of those are connecting for many people, and not for you and I, but people who have all the things, the fibromyalgia-related issues, are probably, and I'm guessing from your experience, are probably the least favorite patients to see on a average doctor's schedule. And I've come to find it my favorite because when somebody's had a lot of distress and you're able to help reframe and understand and work in improving them, that's where you have the biggest impact, because they've often had years of distress. Any comments from what you've seen in working in traditional medicine and training programs?
Absolutely. That is so common. I remember as a medical student working in offices where it's usually the burnt out residents would make some comment like, "Oh, there's a patient with a list," as though there were something wrong with organizing your thoughts ahead of time in writing. Like so patients perceive a judgment, and they're not irrational. They are very much reality-based appraisals. A lot of nervous systems are porous to energy. Like you can pick up vibe. You walk into the room and you know You can't read minds, but you can read vibe. And you may not be reading vibe of judgment of you. You might just be reading vibe of this is a dysregulated person working in a dysregulating environment within a dysregulated healthcare system. But you pick up vibe and it doesn't feel good, which then influences how someone shows up. Shows up in terms of like how they communicate, or when someone is in a state of distress is different than when they are not in distress. There's lots of people for whom, if you ask them a direct question, they are unable to answer that. It's more about declarative language. Many patients tell me X, and then somebody might say, well, yeah, X is the case for me. But do you have X? Oh, I don't know. The neuronormative pain scale. A lot of my patients can't answer how their pain is on a scale from 1 to 10. Those don't mean anything to them. We could talk about zapping or buzzing, all of these other kinds of terms to describe the feeling in your body that just feels off. So I think that one of the things that I'm really excited about is we're at All Brains Belong, we're working on developing, like, it'll hopefully be out by summer, like a free open access tool that patients can have to look at their big picture of all the things, but also something that if primary care does want some tools around supporting folks, that they have some place to get started. And I think that you haven't asked me about this, but I'm going to ask you this. What is long COVID if not all the things kicked off by COVID?
Exactly.
And I think that primary care might acknowledge that they are maybe having a challenge meeting the needs of patients with long COVID. And so if the conversation can shift around, this is something that you may have a stigmatized narrative of fibromyalgia, you may have a stigmatized narrative against ME/CFS, you may have a stigmatized narrative against chronic Lyme. Before you have a chance to have a deep-rooted stigmatized narrative of long COVID, let's just zoom out and have the same conversation, but actually do it well.
And that's one of the blessings of having long COVID. One of the problems I feel that happens is that the medical model is being approached. People are looking at cytokines. They're getting out in such a granular view that people aren't able to see the big picture. And people like yourself and I have seen this from the get-go. They said, within a couple of weeks of us shutting down, I said, we have to open. This is going to be devastating for the mental health of the kids, missing school, the trauma of this experiment, just from a psychological standpoint. So one of the stereotypes, and trying to understand, again, if adults are listening, and this is one that's changed. I'm almost done with the book, The Neurodivergent Mind. I'm sure you've probably read that. Emailed her to get her on the podcast as well. She hasn't gotten back to me, but is stereotypes of people who are not socially able to connect. I would say this when I would talk to parents. Usually a child is, what is autism? People usually have, kids with this have language delay. They have a stereotypical behavior, and they have often difficulty socially and emotionally, maybe more flat. What I'm learning more, that actually there are often very intense emotions with tremendous amount of masking. And I'll share an interesting story of a mom who got ADHD, and they have a child who is 5 or so now, and being evaluated also for the autism spectrum, and very intelligent, but struggling with acting out behaviors, biting kids at school, things that are very much on that aggressive standpoint. Those have lessened. So here's a positive strength-based approach. So we're talking, a lot of those are negative things and getting all this negative attention. Mom was at church, and somebody at church was having a seizure. There was this person had cut themselves, some blood, obviously traumatic. CPR, 911 was called and was taken to the hospital. This child wasn't with mom, and mom came back from this, and the child said, "Mom, what happened?" And mom was trying to appropriately mask, not dumping on a 5-year-old. How was church today? There's obviously certain appropriate masking. You probably wouldn't necessarily say or that directly what had happened, but this 5-year-old child knew something different had happened to mom. And that to me was a sign of just intense emotional awareness. Any comments on that?
Absolutely. So there is again, like you said, there's so many stereotypes. So the idea that autistic people don't experience empathy. Like I remember once getting a new patient of mine who I had met before at one of our community programs, who had been evaluated somewhere else, and the tertiary care report says that the child does not have the separate inwardly focused nature pathognomonic of the disorder. Empathy is present in seamless communication with parents. Ergo, the child is not autistic. This is 2023. And it's just, I think that we really have to get out of this 1900s narrative of autism. That's the way it was first described in the 1900s. Still pretty similar to how it's described in DSM-5, despite a whole bunch of neuroscience coming out that tells us a lot more. For example, not only are many autistic people the opposite of under-empathic, there is the hyper-empathic or hypersensitive to energy person. That is a profile that we see. As I read this report about how autistic people don't have empathy, me, the autistic physician who spends my whole day listening to how the healthcare system traumatizes people, I feel a lot of empathy. So that narrative is just unhelpful. So I really appreciate that story about the child who not only was not separate and inwardly focused, but they were actually more sensitive to emotional feedback from their familiar person. Yes, absolutely.
If you're casually chatting with somebody in an office visit, when I say casually, we're not trying to give a lecture at the medical school on autism, but trying to explain it. I talk about fibromyalgia. People will say, how do you explain it? It seems like there's so many different definitions for what fibromyalgia is. I'll say their symptoms are diffuse body pain. There's a lot of fatigue, insomnia. There's a lot of problems with brain fog, concentration, a lot of those overlapping ADHD type symptoms as well. This has been going on, not explained by an obvious acute illness that's persisting, and it can have varying levels of distress with a lot of other overlapping, and we diagnose it with using clinical history and also support of things like the widespread pain index symptom severity score and measure of severity by using the fibromyalgia impact questionnaire revised. But what would you say, just as I tried to explain briefly, something that's a big ball of different colored yarn that we're trying to untangle, how would you briefly, somewhat briefly, in a paragraph or two, try to explain what autism is?
I might say, and this is how, by the way, there's a whole organization called Autistic Doctors International. It's a thing. So Autistic Doctors International, their leadership describes autism as lifelong differences in how people communicate and interact with the world. That may include special interests, hyperfocus, often sensory differences, anxiety. To even more simply say, there's an autistic speech language pathologist, Rachel Dorsey. I like the way she defines autism as a neurologically based difference that results in a different culture of communication. Or another, I have a collection of, oh yeah, I'm gonna hold on to that one. That's good. I'll tell people about that one. Kieran Rose is an autistic educator in the UK who defines autism as a neurologically based difference in thinking, feeling, and being, relating to how the brain takes in, processes, organizes information, interacts with the environment and people. So we can certainly have these buckets of sensory processing, executive functioning, motor coordination, social communication. These buckets are different. The extent to which something is challenging, it depends on who you're with and where you are.
And
I once had this, when we were preparing to launch All Brains Belong, there's this really memorable event. We had our members of our community advisory board, most of whom were autistic, sitting around in a room talking and planning. And we had a healthcare professional friend of mine who was not autistic, who was in the room and later said, "I've never felt so uncomfortable before. So tell me more." And what they were describing was just like the pace of communication and the style of communication and the energy of communication felt like she didn't feel like she knew what to do or how she was supposed to be. And she was describing this. I said, that's so interesting. That's how I've felt my whole life. There's this term called the double empathy problem. It's coined by Dr. Damian Milton, who's an autistic social scientist in the UK. The double empathy problem refers to that miscommunication happens when there's a mismatch of worldview or communication style. So it's not like these are the normal social communication skills, and then there's the autistic person. The studies that Dr. Milton did looking at this were around miscommunication between autistic people and non-autistic people, and showed that between autistic people, there really weren't breakdowns in communication. There weren't so many breakdowns in communication in this study. It was in both directions, that neither group was very good in understanding one another.
And that is important because if you don't know there's another way to understand and that the brain works differently, you don't see that as, in medical terminology, a differential diagnosis is that, oh, somebody else's brain works differently. And that's going back again to that neurasthenia from the 1800s. The doctors were recognizing there was something different, and the mind and body had such an interconnectedness to how we feel and act. And you have a whole clinic that is there, that is, everyone knows how to provide that care. Everybody probably who works there has some kind of connection, whether a family member themselves. I know you had mentioned on a different podcast interview that you might say, oh, we might interview the patient in their car if they're more comfortable, or meet them in the parking lot, something like that, and understand that, oh, that difficult, non-compliant patient, but what is the story? Little things that I can do in my clinic is, I often, where I'm at now, has the windows with shades, and I'll just turn off the fluorescent lights and keeping it calm. I think if people are listening, is that, oh, I have a hypersensitivity to things. It might be the sound, when people are bothered by sounds more. What do you call that?
You're talking about misophonia?
Yeah, misophonia, where, oh, people being more sensitive to chewing sounds and noises. Now you put that into a cafeteria and noise and sound multiplied can be very distressing. And yet, if a neurotypical brain, we are going to be paired with somebody who has, in some way, interacting with somebody who has a neurodivergent brain, then you can do things to help or harm. Interestingly, the term gaslighting is often used, and I don't like words like that because they're often powerful and not necessarily helpful, and sometimes full of negativity. But how much of gaslighting are when neurodivergent people are not recognized by, quote, neurotypical people on important things. And then there is badgering about the difference. Any thoughts on that?
Yeah, I think in life, the key to the universe is like, how do I come to understand my own brain and my own access needs? And how do I come to understand the access needs of those around me? And then how do I endeavor to meet my own needs without infringing upon your needs? That's like how relationships are supposed to go, I think. And so part of that is that you have to understand the brains of the people around you, and you have to make it be okay. You have to normalize diversity of there's no right way to think, learn, or communicate. And if you name that and you model that and you make it be a place where everyone with all types of brains can name their access needs, then I think we talk a lot about inclusion here. Everybody wants inclusion, they just may not know what it means. Inclusion means that perceived belonging, and only the person can tell you whether or not they feel like they belong. There's a lot of discussion where I am around transitions in healthcare for autistic youth. And really, I think what it comes down to is that people of all ages, you have to figure out how to find out what makes someone feel safe. And you have to figure out what makes people feel safe and comfortable, and you have to do those things. You also have to find out what makes someone stressed out, and you have to not do those things. And until we address that, I don't know that anything else really matters.
And hopefully this podcast and conversation helps people, because again, we have this is meant for somebody who's going through all of the things in fibromyalgia. It's also meant for their loved ones who don't have a brain that operates that way, and that awareness, helping recognize and building that community. There's a survey that is currently on the podcast. It won't be when we go live. That undergraduate student working with communication, recognizing what are the benefits of a podcast as a support for people who are going through fibromyalgia and the impact. And I know that there's some benefit. I hear getting emails from people across the world, the frustration, but hopefully other medical doctors and providers can start to, if they're neutral and haven't already dismissed this, can pause, because honestly, they have to admit, I have mismanaged and misunderstood and miscommunicated with a huge part of my patient population. That can be a frustrating thing, because right now there may be people who don't live near me in Wisconsin and don't live near you in Vermont. I wish you lived in my area. And hopefully I do work with medical residents that I get a chance to connect with that education. And I'm curious, do you have any family practice residents doing at least a month or connection with any of the training residency programs in your area?
Yeah, so we haven't had any residents here. We've had medical students. I've done like lectures for residents, but not anybody like coming and doing any clinical time here. I think it's just you don't get a lot of this necessarily in a traditional family medicine or internal medicine training program. Or sometimes you get the wrong thing. I remember anyway, it's just there's so much unlearning that we all need to do in order to do what needs doing for patients, I think.
Any books that you recommend for
Yes.
patients to learn more? And obviously it's meant for patients at their level. So you want to share what their names are?
I'm scanning my bookshelf to see if there's anything else I should grab, but I'll describe the things that it's interesting. So I think that whether you are a professional or a non-professional, I think that you'll still get something out of both of these books. So one is Never Bet Against by Dr. Lawrence Afrin. So this is the story of mast cell activation disease, mast cell activation disorder. And Dr. Afrin tells us one of my patients, who's not a professional, recommended this book to me. And I was like, I don't have time to read books. What are you doing? Anyway, you got to read this book. Okay. I ordered a book, and it's one of the best books I've ever read in my whole life. And Dr. Afrin tells the story of, hey, I'm a hematologist, a blood doctor, a blood specialist he tells the story of, I had to unlearn a lot of what I was taught about a lot of things. And he tells the story of the patients that he sees, very much the way you open your book. Anyway, he has about 400 pages worth of stories of his patients, but he breaks down, he basically describes how it's like for any lens that you're talking about all the things, you may not be capturing all the things. So you may, for example, you may capture fibromyalgia, irritable bowel, restless leg syndrome, interstitial cystitis, POTS, migraines. You may capture a lot of the things, but if you're not necessarily talking about hypermobile Ehlers-Danlos syndrome, or you're not specifically talking about, this book doesn't talk about, talks about autism very briefly. I appreciated seeing that. Another book that, but again, I have to imagine that the folks I see, the group of people I see, that pattern, like it jumps out at me. You can't unsee it. So when if someone's learning about anything else, I remember in my training, there's somebody I worked with who was really interested in fibromyalgia, who taught me a lot about fibromyalgia, so much so that I would spot it like for really early in my career. This is a big picture book. And then another book called Disjointed, edited by Diana Joven. This is a story written, it really does a very good job, like walking that ground of being useful to professionals and non-professionals. And it tells the story of hypermobile Ehlers-Danlos and hypermobility spectrum. Does it have all the parts about things? No. But is it a really good book to really give a big picture understanding and some practical strategies for feeling better? Yes. But those two books.
Those are a couple topics that I haven't covered yet on the podcast. And when you have a book, the editor said keep it in the mid 200s for a practice. Those are thicker and deeper reads, but it's interesting because I've had this idea that I think is under all the things, under fibromyalgia and related issues. And it just happens to be the autonomic expression is in a different spot. And it has similar triggers. So somebody gets a migraine, somebody gets IBS, somebody gets neck pain, back pain. This person gets hives. I've had a patient of mine who doesn't have autism but has ADHD, was having debilitating hives. That when his ADHD got treated, he could go on an airplane ride without having the rest of the trip
because the autonomic nervous system was
because
regulated.
he wasn't overwhelmed about the anxiety about flying, and pretty much has only had one minor flare when he was having flares every week. And that practical connection, I am hoping to do a series or discussion interview talking about the mast cell activation syndrome, talking about Ehlers-Danlos, and
Cool.
so those are on the list of things. And then cool topic, getting introduced to you from another podcast and said, you need to talk. This is somebody who, and I'll ask you this question. She said to me, I don't know anybody else in the country like you, Dr. Lenz, who does what you do. And not that she knows everybody in the country. And then she said, wait, you got to talk to this doctor in Vermont. She calls it all the things. And that's when I emailed you the next day when I got the information. So I don't know, obviously you have your own practice and you have a group that's getting it, and hopefully more people in the country can take that. I don't know if it's bold. Is there much pushback in the broader medical community, or pushback or incredulousness towards your framework or management of any of your patients that you're aware of or implied?
I think that when it comes to the medical management of things that autistic adults struggle with, hope certainly that we're providing something that, because I think people like being able to send their patients for additional support. So as far as we're not doing anything risky or controversial, we're just like helping people feel better with fairly benign over-the-counter medicines and supplements. So I think it's more about like the model of community health, bringing people together, having shared understanding. Like it's not, I wouldn't say that we're The way that the healthcare system often like quackifies those on the fringe, I don't know that there's anything we're actually doing
Sure.
that they would necessarily regard as fringe, but it's something I definitely think about. And I think it's just really important that it's not, I think all too often patients are forced to choose between the traditional model not. I think that there's a whole lot of people with a whole lot of knowledge and expertise, but really at the end of the day, the patient knows best. The patient knows what things are connected. The patient knows when they feel better and when they don't. And I think that's really all we're doing here is naming that.
And I think that would be the only maybe pushback is are they naming it too easily or too commonly? But I think hopefully as more patients, often there's maybe a couple where one sees you and the other one is seeing the regular doctor or the other doctor, that's common, and having feedback like, wow, our relationship's better. My spouse is doing better. And this doctor really, this is the first doctor, and I'm guessing you've heard this before, that really understood me, having that positive connection. I'm starting to see that in the area around here where you start to have family that you're treating, and it's not just the parent, it's their teenage kids, and or vice versa, where you start helping pretty big community and it ends up standing out. You are out there as somebody who really advertises as that's what you do. I'm there doing that amongst primary care of all these other things, but naturally over time, I've had a practice that has moved in that direction just because if they were getting the proper care at their own doctor, they wouldn't need to come to see me.
Yeah. And I think that the system gets in the way. If you have to see a patient every 10 minutes, a community health education program that I consult to, and one of the patients on the advisory board asked, "Can I ask you, why does my doctor only spend 10 minutes with me?" And I say, "Oh, let me tell you what the healthcare system, like this was new information to the patient." So I think that just transparency is the way out of chaos. I think that if it's not that the individuals within the traditional system are unkind or not compassionate or not interested, it's that like the pressure is just unbelievable.
And that is why I wrote my book and do the podcast is there are some time limits, and there's probably a good time for reflection after an initial diagnosis to pause, to consider, digest, come back. I often go over my lunch or have my last patient of the day go for a longer period of time and trying to give that proper amount of care without getting too far behind. But the satisfaction of helping somebody who's struggling and just having the information that somebody understands what they're going through. And the way I understand this is not through me experiencing this, but through hearing the stories and just having that compassion of wanting to help people who are in distress and seeing how these all disparate things are connected. One analogy that I use is like the movie The Sixth Sense with Bruce Willis, where he's dead the whole time and you find out at the end of the movie and all the clues were there. And I think there's often this, oh, the clues were there. No wonder. And that explains things. And hopefully this will help people have a better quality of life. Any other last thoughts for the listeners?
The opportunity to shift or broaden your narrative of your own health just a lot. It just relates to also better understanding your access needs of your physical, emotional, interpersonal. I have the kind of brain that when someone asks me, "What's your take home point of the past 2 hours?" And I'm like, let's think about that. Oh, let me make a completely new statement that I didn't say anytime over the past 2 hours. Was saying is the way I connect access needs to fibromyalgia related conditions is that if I, for example, I'm a person who needs sleep, I don't know that's my access need until it's taken away. And now I am really having a hard time. Or I don't know that I have an access need for blocking histamine. How would I know that? And then all of a sudden, I stop my famotidine because it has fallen out of favor to be on chronic H2 blockers. Now, all of a sudden, I'm having a hard time functioning, not with GI stuff, but with other stuff that, in fact, that famotidine was helping a lot with. Or just there's all kinds of examples like that. I have an access need for movement. It gives me dopamine. And then something happens, I get an injury, I get something, this or the other thing, and now I can't keep up with the exercise routine. Now I have MECFS, and now exercise actually makes me worse right now at this stage of my illness. One of my patients once said, I don't know what my needs are, I just know they're not being met. And I think that's an important place to start.
And one of the things to acknowledge is that most people who have fibromyalgia related, at some point early in their life, they didn't have hardly any of the things, or they had fewer things, unless somebody was in a very high stress environment that is not conducive to any child. Didn't ever have in a house with substance use, with often one parent, stress, multiple partners, etc., that are in and out of the person's lives without the stability, and often not just stability economically, but often things that were categorized as abuse. Recognizing that most people were doing well and could function until something happened. And often they can't understand until it's gone. And it's one of those things in medicine that I've just learned from developmental biology when you're in med school, how so many things have to go perfectly right. And believe that we have this body that's perfectly designed, but there's variations. And then you have an environment that is also some stress and becomes, like you've said, that hypersensitive nervous system. If you're hyper alert and hyper vigilant, that when there isn't true, real harm, danger, that causes a lot of ongoing tension and stress on the body. That's just makes it harder for people to function and to recognize, like we're talking, there's a lot of people out there who have these nervous systems, and if you're at least aware of it, that can be helpful. There was a study that I talked about in a podcast episode a year ago from Spain, where they were just talking with people with fibromyalgia, and it was a 7-week, 2-hour education sessions that they were talking about having the hypersensitive nervous system and finding coping strategies, and that reduced fibromyalgia score by 25%. So having that awareness and education is so helpful for your patients to understand, oh, and then you add their spouse, and then they can not be irritated by their spouse, but actually support them and then understand them. But it's been a pleasure to have you spend all of your valuable time here. I know that the who have gotten a chance to share or hear your insights that you've shared have hopefully gained a lot, and hope all the doctors and medical people in the world have gained a lot, and hope to, if this conversation is evergreen, this is something that a lot of the basic stuff was going on in the 1800s is still going on now and helping people. So thank you.
Awesome. And the other thing I'll also mention is, even though my medical practice is limited to Vermonters, all of our community and education programs are open to everyone. They're mostly all virtual and they're open to everyone. I definitely would invite any listener looking to learn more about neurodiversity and neuro-inclusive living to come on over.
Great. I'll have links to your website and connections on there on the show notes. And if you have any other questions, that you can email me as well, and maybe we'll have another conversation down the road
Awesome.
if there's other questions. But thanks. Yeah, I'll cut it off there. Any comments on any of the podcast episodes or any of what you got a chance to read in the book at all?
The thing that was most interesting to me was at the end when you're talking about the short chain fatty acids, and in particular butyrate. It made me think about mitochondrial dysfunction, and I wonder if, anyway, I'd never seen anyone write about butyrate. I follow this dietitian on Instagram who like every day posts something on butyrate. And I'm like, I don't understand any of this, but I think I probably need it. Tell me more about
Yeah.
that.
That's where the lifestyle medicine, plant-based aspect, and I wanted to purposely make sure I wasn't just, oh, here's meds. I wanted to make sure as best I can add in the lifestyle. So it's completely fascinating as the whole microbiome and understanding of that. And butyrate's made from plant-based plant fiber processed by healthy gut flora. If you want to look at it, it's like how much would you pay to lose weight? Because the short chain fatty acids are activating the GLP-1 receptor agonist, and with all of the semglee and all of those that are being very successful, that's the same mechanism that the short chain fatty acids are. And we can't pay $1,200 a month for people to solve our healthcare obesity crisis. So it helps with preventing cancer by changing the pH, turning off likely cancer genes in the colon. It works to act as local lidocaine. So when you give an enema of that and then put a barrel pressure sensor in the colon, as I probably mentioned in the book, it decreases the sensitivity, pressure tolerance increases, and it works to allow delayed emptying in the gut, and actually works within the brain. So the reward center of the brain, evaluation of things that are perceived as pleasurable, is diminished. So all those calorie-dense foods. So it works on the brain as well. Of course, if you're not eating a lot of fiber and you don't have the gut flora to process it, you might have a lot of bloating initially. But I would say, and I mentioned in the fiber world, some of this mitochondria theories of causing this, and I think that's in that very granular level that some people will attribute that with the keto diet being out there, if they're somehow talking about that.
Extreme things make me uncomfortable. The whole food, plant-based diet, ways of getting short-chain fatty acids, I think are the way to go. And I think it is interesting from a mitochondrial function standpoint, though. Like one of the people on our task force is a psychologist, an autistic psychologist who has all the things that she calls long COVID. She says, I became a carnivore and I'm just eating meat all the time and it's all I eat. And I got better. That's really interesting. I don't understand that. And then somebody else, I presented this at the task force meeting, and a patient, a not professional patient, says, when I had ME/CFS 20 years ago, that's what I did and I got better. I said, what? I don't know if it's the high dose CoQ10 or the carnitine.
My assumption is this: all the processed carbs are gone, and probably 80% of their calories were coming from processed carbs with no fiber.
Yep.
People who eat a keto diet long-term have a shorter lifespan because of cardiovascular related issues.
No, absolutely not. And there's all these people on there like intermittent fasting. They're doing all kinds of wackadoo things that are just terrifying.
One thing that just popped into my head, I taught a course years ago for kids, for parents of toddlers and preschoolers, and it was on picky eating. I went on the morning local TV show talking about this and did a community thing. And one of the things that just popping into my head is how hypersensitive, and on the spectrum, you'll find that they only eat hot dogs with buns and ketchup, and that's all they eat. Is it fair to say that, yes, would the transition to these other textures may be a bigger process, but it doesn't mean it can't be done, and it may take a lot longer to undo set things over time? That's a stereotypical one I'll see in children who are on the spectrum.
Two things. One is there's a concept of a same food. A same food is a food that always tastes the same. So like a lot of the stereotypical restricted foods, they're actually same foods. If you can introduce something that is like a nutritious same food, that might actually work. Like a cucumber is a same food. It pretty much usually tastes like a cucumber. A blueberry is not a same food. Sometimes it's tart, sometimes it's sweet. What's up with that? That's really messed up. So if you have the kind of brain that derives safety from predictable systems, and autistic brains generally are that, the idea that sometimes a food is sometimes sweet, sometimes sour and tart, and you can't tell the difference. And so that's what I have to say about that. The other thing is that there's a subprofile of autism. It's really right in the smack middle of autism and ADHD. It's a trait that we don't use here, but is used a lot in the UK and Australia, called PDA, pathological demand avoidance. A lot of times, and so that's just, those are hypersensitive neuroceptive systems where autonomy is an access need. And I don't have a formal PDA diagnosis. I'm a PDAer. So is my 6-year-old. If I pick a food battle with a PDAer, I will lose because autonomy is an access need. So I think that a lot of times when people get into food battles with picky eaters, they're never going to win if you're dealing with a PDAer. And so some of the strategies that like we might say about involve the kids in their cooking, you're really actually supporting autonomy. And that's why it works.
That is some of the advice we gave in the class, and it's in cozying up to somebody instead of directly confronting them and being a partner and seeing where they're at. And often I'd say there's number 1, 2, and 3 foods. 1, foods they eat all the time. 2 are sometimes depends on my mood, or if it's in a soup or it's by itself. And then 3 foods are, if it's on the pizza, I'm not eating the pizza because the mushrooms just totally were too not the same or whatever. It does cause me to consider that if somebody has more than the average rigidity in their diet, is that something that should prompt a clinician, a doctor, to consider this non-compliant person who won't change, or a dietitian that finds that there's often you hear, oh, my spouse isn't going to want to eat that because they're really picky. And I have this chance at my pediatric newborn transition to solids visit saying, if one of you two are picky, this is your chance to process that in an adult way. And maybe I don't eat that, I don't eat vegetables, which is often the Western diet, just whether you're on the spectrum or not. But it does offer that long-term, long goal solution. And again, walking alongside somebody, recognizing that, you might be more sensitive and understanding. I was thinking of same foods as foods that have about the same amount of fat and salt in it, which I guess is maybe where we can eat hot dogs and chicken nuggets, and that might be the same, or with chips and French fries, where the salt and fat are relatively high versus the low-fat cucumber or something, quote, whole food plant-based, which is naturally much more lower in fat and salt.
The salt thing is really interesting. I think that there's a lot of people who there's salt. I don't really understand this part, but I think there's probably some like sodium, potassium gated pump stuff with all the things. And I think that there's the way that some people avoid drinking water. It may be because they have interoceptive differences and they're not thirsty, so they don't drink. It may be that they're actually trying to not, like, they might actually be regulating. Their thirst centers might be compensating for whatever something going wrong with their tonicity. It is interesting. I'm a person who has all the things, doesn't drink any water, no matter how potsy I am. And I'll go to town drinking coconut water. I think I need the potassium. I don't know.
It's all makes you pause and wonder, as we're all re-evaluating our life as we go along this journey and trying to make more. And that is a concept that I didn't learn in medical school. And it's something that you're learning as you go along, and having that, I want to say, open mind. As I say on the podcast, I want to do an evidence-based approach. If you talking about long haul COVID and chronic Lyme, and sure you're in Lyme country up in Vermont. And so recognizing that, yes, you have pain, you had Lyme, but it's not persistently infected. We don't have to give all these other things.
Same way as your concussion or your surgery or pregnancy was your trigger.
Exactly. It's been great to have this awesome conversation.
I'm to bed.
Yep. Thank you. And I'll probably get this out probably in a month and a half or so. And I'll get a chance to make this into multiple episodes. I'll share it with you. Okay. Thank you. Bye-bye.